Good morning, my name is Pimentel from Centro Hospitalar do Baixo, Vouga, in Portugal. First of all, I would like to thank the organizing committee for this opportunity to participate in this 9th edition webinar on cancer research and therapy. Today, I will present the case of lupus mastitis, which is a rare differential diagnosis of breast cancer. So, lupus peniculitis, first described by Kaposi in the late 19th century, is a chronic subcutaneous fat inflammation caused by an autoimmune reaction associated with systemic lupus erythematosus. Lupus peniculitis occurs in about 3% of patients with SLE as unclear etiology and occurs mostly in the arms, buttocks, face and thighs, and rarely affects the breast. When it does, the condition is called lupus mastitis. This entity most commonly affects middle-aged women with a mean age of 40 years at diagnosis and has rarely been reported in men. Lupus mastitis can occur in patients with an established diagnosis of SEL or Cani-Raldit. On physical exam, patients usually present with a breast tenderness and pain, sometimes with palpable masses and skin abnormalities such as erythema and ulceration. Imaging studies usually show a irregular shaped mass. For these reasons, differential diagnosis includes breast carcinoma and tissue biopsies performed to rule out malignancy. Pathologic features of lupus mastitis include perilobular and periductal lymphocytic infiltrate with vasculitis. The treatment of this condition is directed to the underlying cause, SEL, with antimalarial drugs such as hydroxychloroquine and others like systemic steroids. Lupus mastitis does not require surgical treatment, and surgery may even result in exacerbation of the disorder. I now present to you a clinical case of a 35-year-old woman who presented to the emergency department with a painful right breast mass with 1 month of progressive growth. She had SLE with renal, hematological, musculoskeletal and cutaneous involvement and was medicated with hydroxychloroquine 200 mg per day, prednisolone 7.5 mg per day, and mycophenolatum of til 3 grams per day. On physical examination, she had a swollen, hardened breast with a poorly defined mass on the outer lower quadrants, as you can see in the picture. No palpable lymph nodes were identified. Ultrasound revealed a lobulated vascularized 5 cm mass with liquid areas, suggesting a possible abscess but not excluding a malignant lesion. The patient was treated with ibuprofen and a course of antibiotics. The patient was re-evaluated 10 days later. Due to progression of the inflammatory signs, as you can see in the picture, the mass was drained and biopsied. Purulent-like drainage was observed. Cultures of the liquid were negative. Histopathology analysis revealed a fibroinflammatory process with perilobular and periductal lymphoid infiltrate, and lymphocytic vasculitis, which are highly suggestive of breast involvement by SLE. No malignant features were identified. The patient was referred to the rheumatology department, and the dose of hydroxychloroquine and prednisolone were increased to 400 milligrams per day and 10 milligrams per day. And as you can see, this resulted in a significant improvement with notable decrease of the inflammatory signs after 20 days. Reviewing the clinical case, our patient had a history of SLE and clinical features which favored the diagnosis of mastitis. Thus, we first considered an inflammatory rather than a neoplastic lesion. After progression of the symptoms under therapy and considering the ultrasound findings could not rule out malignancy, corneal biopsy was performed. Pathologic examination revealed features highly suggestive of lupus mastitis without malignancy. The patient was treated according to the underlying disease. Lupus mastitis is a rare entity with an unclear etiology. To date, only a few cases have been reported in the literature. This condition should be considered in the differential diagnosis of a suspicious breast mass on mammography or ultrasound, particularly if the patient has a background of SLE. Since most patients with lupus mastitis are young adult women and the disease can manifest with single or multiple intramammary nodules, it is often mandatory to rule out malignancy. Histopathological findings of lymphocytic lobular peniculitis with fat necrosis are highly suggestive. Lupus mastitis may be exacerbating by surgical trauma. Therefore, needle core biopsy should be preferred to open excisional biopsy, and surgery must be avoided. Antimalarial agents and corticosteroids are the first-line treatment agents for lupus mastitis. However, therapy is empirical due to the paucity of cases reported to date, and recommendations cannot be generalized. In conclusion, in case of a breast lesion suggestive of malignancy, patients with SLE should be investigated for lupus mastitis. The diagnosis of this rare condition is histological, and the treatment is directed to the underlying disease. Thank you very much for your attention.